Okay, we've got a couple minutes here. We'll see who shows up. Wondering, John or Georgiana, did you manage to look at the articles I sent? There were some various interesting headlines from CDC on travel affidavits nationwide and other interesting developments. I've kind of just forwarded stuff thinking it'll get disseminated from you.
I saw the New York Times one.
Right, I think I sent a couple this morning or in the last 12 hours.
Did you see that comment from Michael Osterholm, who's the head of viral disease and research, I think at the University of Minnesota, talking about the fact that this Brazilian strain, Manaus, I think that's Brazil, and said that it's worse than they thought, and that Manaus had been, they thought, reasonably under control, and it had dipped, the infection rates had dipped quite dramatically in the recent past, and this new variant basically just went crazy. And he said they don't really quite understand it, but they said he was fearful of it, and he talked about, gosh, it was going out to mid-May. I mean, not that the attenuation of the thing could go out that far, and I mean, he was quite shocked, and the scientists were a little bit shocked about how virulent this thing is. So there's a lot we don't see, you know.
What's the new term that I've heard recently is it's like an immune escape or immune, it's where the variants are popping up faster than the various vaccines will be.
I mean, no
I
question.
don't know if immune escape's the right word. Kurt,
It is escape, yes. I've heard the term escape from the
Yeah.
Stanford infectious disease people.
right. Okay, it's 1:01 and I want to make sure, do we have a quorum? Jordana or Lindsay, can you help me? Tori's here.
Yes, we have quorum.
Okay, let's start this meeting. I'm going to call the meeting to order. And let's see, regarding, is Marky here yet? Is she coming today?
Marky won't be here today, so I'll be the voting member.
Okay, so Bill's here in Marky's place. We've got Kurt, we've got Linda. Okay, Jeannie, thank you all. Thank you all for being here today. Let's get started. We've got a full day ahead of us. And I wanted to, reviewing the agenda right up front. I know we're going to go into an exec session fairly quickly here. We've set some time aside for that, about 40 minutes, but we may try to break out faster depending on the amount of questions, but I think we may try to squeeze a little time out of that. I've already briefed John Ely that it may go faster, but if it doesn't, I understand. I also wanted to say, I think it's possible we could go past 3:30 a little bit. We did not have a round robin included in this agenda. And if we need to add or delete that at the beginning, I think it would be nice to be able to put that in maybe at the very end, Jordana. Do we need a motion to do that? To alter the agenda in that way, to add a round robin?
Yeah, if you're going to amend the posted agenda, Greg, I believe you need a motion.
Well, before we do, is there anything else we want to add, Jordana?
And I would just say historically, we've added those round robins at our regular meetings. And we have been having mostly special meetings where we're coming with a specific purpose and haven't included the agenda item of a round robin.
Got it. Now, so I confess, I'm not sure. Is this a special meeting or is this a regular meeting? They blur together. So now also I think the reports, our reports are going to be pretty comprehensive today, as I understand it, regarding the various things that have come up. So, okay, I need a motion then to modify the agenda to include the round robin at the end.
Please
It's
include
got
the round robin.
Okay, Dr. Kurt, I got a second from Brent, and then I've got a second from Tori also. Okay, so all in favor, hands up, it's a third. Aye, okay, we're gonna add that at the very end. If that's all the business there we have to do,
I have one question, Greg.
sir,
Are we getting, do we know of any specific public comment that's happening today at all?
no, there is no public comment on this today, but I did want to point out that we've received and disseminated letters very recently, up until very recently from the public, and so those are, hopefully you'll all have those in your mailboxes if you haven't seen them already. But today is not a public comment day.
Well, I was just going to say, and given that, I think we do want to make sure, I think, that at some point soon, hopefully, that the public can be felt that they're heard. I've seen quite a bit of talk about the fact of a 3-minute time limit and so forth and so on. And I think, when an individual has 3 minutes, that's one thing. And again, the Restaurant Alliance is a good example. When they, supposedly represent 1,500, 3 minutes becomes a pretty short day in court. And I just want to make sure that not only from a practical application standpoint, but also from a political standpoint, that these people feel that they're being heard. And how we get to that point, I don't know, but I think that's an important issue, because right now, from what I've seen, they feel that not only are we being overly conservative and arbitrary, but they feel they're not even being heard. And I think that's an important thing. Anyway,
Right, thanks, Brent. I think we've all heard those comments, and I was going to say, I was going to look to John Peacock or John Ely to opine on the 3-minute rule, which is what we've always used in our public comments at the county, and I assume the city has something similar. If we want to schedule a public forum where people have the ability to speak at length, I think that's something we can talk about doing. But I'm already it's already getting away from me. But before I'm going to recognize Tori here who had his hand up.
Thank you, Greg. Greg, I had a question for you about agenda additions. I sent you an email that the city of Aspen would like to have a conversation during this meeting today about a date certain for next week concerning the 5-star program and procedure for moving to Orange. So it'd be my intention to have a discussion about setting a date certain for level restrictions. Is that something that we'd need to add to the agenda, or could I just make you aware that it would be my intention to have that discussion sometime around the 5-star program or procedures for moving to Orange discussion?
I was going to suggest it would come up in questions after we've had those presentations, because they may cover a lot of that.
Okay.
If we need to modify the agenda, I'll look for John Peacock or John Ely to give me a nod that we would need to, but otherwise I think we're anticipating questions from the board where that could come up.
Great.
Does that sound right? Nods from John and John. Just checking. Okay, I think I got a thumbs up. Okay, with that, I want to get us. Let's see. We need to. I need a motion to approve the previous minutes in a second, and we'll vote on that and move on.
I made some amendments to the meeting, minutes from the last meeting that lists the board members, the alternates, and the ex officio. With that included, that's fine.
Okay, we have a motion from Tom Kurt, and did Linda, was that you seconding that, Linda? Okay, all in favor? Aye, okay, we've got it, we're good. I'm gonna keep moving in here then. All right, so now the next thing is we need a vote to go into executive session. Need a motion and a second and a vote, and then we all need to make sure we have the links to get us there. Is this it's a separate Zoom call, correct? So we're going to leave this meeting and then come back to it. I want to confirm that. That's how we normally do it.
That's
Yeah,
correct.
okay.
Move we
Okay,
go
thanks.
into executive
Motion.
session.
Seconded.
Okay, all in favor?
Interrupt, Greg,
Yeah,
real
sure.
quick. We need to read the full agenda item, so if you can ask for a motion and then read the Restaurant Alliance.
Okay, I will read the full agenda item here. It's a motion that we've just made to go into executive session regarding the Restaurant Alliance versus Pitkin County litigation pursuant to CRS section 24-6-4024B. And I believe that, is there more?
Make a suggestion, given the topic, that we broaden the exec session to add one additional topic, and that is enforcement of public health orders. Quite frankly, it might just come up, so I'd rather have it part of the motion.
Okay, so we would add a conversation about enforcement of public health orders. Can I have an amendment on that, Tom, and then Linda?
So moved.
So moved from Tom, so moved from Linda. Okay, all in favor? All right, okay, and good luck. We'll see you in an executive session imminently, and then we'll come back here after. This is like synchronized Zooming. This could be an Olympic sport. When Jordana pops back in, let me look at the agenda here. Suzuhu is going to actually be up next. She may be with us already. Next discussion is about the schedule for regular Board of Health meetings, term limits, appointments, and elections. And Suzuhu, I don't see you yet.
Oh, I'm here.
She's
Can you
here.
hear me okay? Yeah.
Oh, there you are.
Hi, everyone.
Okay, take it away.
Yeah, so this is kind of regular business, but I just wanted to quickly go through our proposed meeting schedule for this year and also talk about term limits that are coming to an end. We had some positions staggered when the Board of Health was initially created so that we didn't have a full turnover at any point in our working process. So we have 4 seats that are up, whose terms are up this year. Raleigh or Lindsay or Abril, if you wouldn't mind screen sharing the slides. So the 2 sort of geographically or jurisdictionally allocated seats that are up are Tories for the city of Aspen, as well as Markey's for the town of Snowmass. And so Charlotte, who many of you know, will be reaching out to everyone whose terms are up in April, just to inquire if you're still interested in being a part of the Board of Health and wanting to renew, or if you would like to transition off the Board of Health at this time. And then the 2 at-large seats that are up for their terms in April are Jeannie Seibold and Brent Miller as well. And so as you may recall, we had Jeannie and Linda come on to fill in some unexpectedly vacated seats. So there's a little bit of a staggered there with our at-large positions as well. So we have a few members that are not transitioning off necessarily, but have their term limits coming to an end. So we're hoping to have that conversation with each of you through Charlotte to see if you're interested in renewing. We will have our regular application and our renewal application up on our county website. It'll also be posted on the Aspen Daily newspaper every Monday during our recruitment process, along with every other community board that has open positions for the county. So you can switch to the next slide. Yep. So our applications are going to be available February and March. Those are for new applicants as well as renewals. The decisions for appointments are all made by the Board of County Commissioners. We definitely look to the city of Aspen and the town of Snowmass Village for recommendations for who may fill those positions, if we will have Tori and Markey continue, or if there's recommendations for other individuals that they would like the BOCC to consider. The interview process is typically done in March, may go into April, and then the final appointments are typically made in April. So we should have that process getting started here in the next week or 2. And then during that time, it's a little bit of an interesting timing here, but we also have our officer election. So as many of you know, or all of you know, we have a board chair and a board vice chair or co-chair. And so we'll have those elections in March. So earlier when we were talking about regular meetings versus special meetings, by state statute, we're required to have quarterly regular Board of Health meetings. Obviously, we've had much more frequent meetings with the pandemic right now, but wanted to propose a schedule for those quarterly regular meetings. Based on our bylaws, we're required to have that election for the chair and vice chair held at our first regular meeting of the year. So if we go back to the schedule that we had previously discussed, the second Thursday of every third month, starting in March is what we would like to propose. For the sake of time, I know we're already over time right now, are a little behind on our agenda. I won't go through the details of the chair and vice chair's responsibilities, so we can skip over the next slide. And for those of you who are interested in those positions, you can definitely reference the bylaws to see the information here. Yep, we can skip that slide. And then the terms and elections. So the vice chair and chair positions are both 1 year positions if you are interested in running. So again, we'll hold those elections in March. And then the last slide, if you can switch to the next one. Yeah, so this is the schedule that we wanted to propose for our regular meetings. So March 11th, June 10th, September 9th, and December 9th. If that works for all of you, we just need to have a motion and approval for these regular meetings. It doesn't mean that we won't continue to have these special meetings, but it's just kind of the process that we need to follow. And then that March 11th meeting is when we would plan to hold our elections.
So Suzuho, your motion then would just be about the regular meeting schedule, or would it be about we don't have to vote on anything else here, it's just the
Correct.
schedule? I'd
Yeah,
like to
so
have
I
a
can
motion to
pause
that effect then.
Yeah, I can pause and see if people have questions about the appointment process at all, the application and appointment process. The application is open to anyone who wants to apply, and then the BOCC reviews the applications and interviews. But any questions around that before we move to the?
I would just love to say to everybody who's been serving, I want to express my personal gratitude, and I think the gratitude of the community to you for the heavy lift you've done, especially those of you who I cajoled and talked into taking on a Board of Health role, only to discover that it was a quagmire of sorts, or what do you call it, a briar patch. And I'm so grateful that you've all stuck around, and I'm hoping that everybody who's on now would re-up and stick with us. It seems to me that when you're in the middle of a pandemic is the last time you want to have to reorient new folks. So that would be my personal pitch to all of you. And thank you.
Thanks, Greg. Yeah, we echo that appreciation. We know that there's been a ton of work you all put in, and the stability of your presence and your involvement and your support and just collaboration through all of this work has been greatly appreciated. So
there's the joke about how if you miss a meeting, you'll be appointed to something, right? But this is almost like we all knew we were signing up for something, and then the game changed completely for all of us. And so anyway, I'm just grateful that we're all here doing this, and I'm honored to be on here with you. I'm probably not going to nominate myself because I don't believe in nominating myself to things. If somebody wants me to stick around and work, I'd certainly consider it. But just so you all know, that's kind of how I like to roll. I don't want to run for anything, quite honestly. But if I'm nominated, I'll consider whatever, however. That's my 2 cents worth. Could we have a motion on that schedule?
I would make a motion to approve the regular meeting schedule as presented.
Seconded.
Tori and Dr. Kurt, we have made, okay, all in favor? Aye. Any other business here, Suzuho?
Nope, that's it. And just for people, kind of to your point, Greg, in March during that meeting, we will ask people in person if you want to self-nominate or nominate anyone to be considered for the chair or vice chair position, and then we would hold that election here during the Board of Health meeting. So just to be prepared for that, if you're nominated, you're welcome to decline, but we hope that you all will consider those leadership positions as well. Thank you.
Great, thank you. Thanks for taking care of business there. If we're ready, we're going to move on to the data overview with Josh. And let's see, he's got 15 minutes allocated to that, but I'm going to hold him to 14.
Try to fly through it, Greg. Next slide, please. Okay, so this is showing where our incidence rate has been since November 1st through the 27th of January. So the orange bars here indicate when we were in the orange level restrictions, including the orange plus or orange plus plus levels. And then the red bars indicate when we had made the red level restrictions effective. And Jordana, I was going to hand it off to you briefly to walk through this, but I just wanted to give an overlay of that information.
Thanks, Josh. Yeah, I think I just wanted to bring us back to November, which seems like a long time ago, and a lot has happened in a short period of time. And walk us through how our incidence rate, began to increase. The board reacted by, considering red level measures and opted to select some of those to put into effect a stronger orange plus measure. Again, incidence rates continued to increase into December. We came back in the middle of December, and the board opted to put into effect additional restrictions that were red level restrictions, but tuck them under this orange plus plus measure. Really recognizing that the one measure in the orange plus plus level that we did not put into effect was the closure of indoor dining. As the board had the really tough decision about how many people that would impact, both the mental and economic impacts of that decision. And then ultimately, in January, voted to put into effect the full level restrictions, closing the indoor dining piece. Recognizing all that was difficult, allowing us some extra time to be able to provide that economic support, and citing the evidence of looking at other counties who had put in red level restrictions and had seen incidence rates decline. And so, as we come into the meeting today, we are seeing our incidence rates decline. I think we can all take a breath and know that this is good news. We acknowledge that there are a lot of factors that probably play into that decline. And today, Josh will present some more data, and then we'll have a discussion about what it means, what the additional projections are for when we would hit that level of incidence rate of 700, to be able to look at going into that orange level restrictions. Tori. Oh, sorry. I'll let Greg call on you.
Sorry, I didn't see him, but Tori, sure.
Oh, yeah, just thanks. Just because it's completely relevant to the slide that you have up right now. Jordana, did you guys ever overlay an occupancy tracking along this same timeline?
Josh, you can answer if we have that specific. I don't believe we have that specific graph.
We did pull some data from what's it called, decimetrics. And so we did run a correlation to look at that, and there was a slight correlation.
Great, thank you.
Sure. Jordana, anything else, or?
Back to you.
Okay, perfect. So last thing I wanted to point out on this slide is in the last 14 days, we reported 165 cases. Whereas in the past 7, we've only reported 45 cases. So the hope is that if that trend continues of seeing only 45 cases in a week's worth of time or even less, then we will continue to see that incidence rate continue to decline. Next slide. So I wanted to show these there's 3 different slides here that I wanted to show. The first one here is showing our local data. So the bright red line, that's our current incidence rate and trajectory since January 11th, when the board first announced these red level restrictions. So you can see that we have this data up through the 27th, did not include today's data since we still have a few cases coming in here and there. And then the lighter or the other red colors, so the light pink, the medium pink, and then the darker red color, that shows where we could end up going over the over the next week or so, given an average number of cases per day. So if you look at the light pink, that's assuming that we get 0 cases per day over the next actually the next 2 weeks. You can just see where our incidence rate would go and how quickly it would go. So the reason of showing you a 0 per day average is to understand what is the absolute earliest day that we could end up getting to an incidence rate of 700 using our local data. And that would put us there at the 29th. If we had 0 cases per day over the next, today, tomorrow, and so we know that we likely will not get 0 cases, but that's just where we could end up. The middle line there, that medium pink, that's if we get an average of 7 cases per day, and that's about what we're averaging right now. It's about 7 cases per day. So if that were to be the case, then we would hit, move under 700 on the on the 1st of February. If we continue to average 7 cases per day over the next 3 to 4 days. And then that darker red line is showing you if we do 10 cases per day on average, we will peak or dive below the 700 for just a day or two. And then we will move back up above that 700 line. So the difference between getting 7 cases per day on average and 10 cases per day on average is quite a difference because that 10-day per average will ultimately cause us to stay above that 700 threshold. So, maintaining 7 or 8 cases per day is going to be extremely important moving forward. Next slide. And so now this next slide shows you the state data. And then the slide after this, I'll compare both of them, but wanted to show you them separately since the last slide is a little bit busier looking. But this one's looking at state data. And we know that the state data lags our data by about 2 to 3 days. And there's actually, you'll notice some significant differences with the state data that we always try to figure out, exactly why their data is not matching ours perfectly, but it's not always easy to do so. So you'll notice there that if we had 0 cases per day over the next few days, then we would hit below 700 on the 2nd of February, assuming that we had 0 cases per day. Using the state data, if we averaged 7 cases per day, we wouldn't get there until, I believe, February 9th or 10th. So, just comparing the different data sets that we have using our data versus state data, you can just see how there's some discrepancies in, how soon or how long it might take us to reach this 700 threshold. Next slide. And then this last slide here is just comparing all of them together just to show you kind of what the differences are between state and local data. So you'll see that we flip-flopped back in the middle of January. The state and local data did a little flip-flop, and we're not exactly sure why that happened, but there always tends to be this lag. So you'll see that the state data does usually catch up with us. It just takes a little bit longer for them to get all the information from us and then calculate it into their incidence rate. So again, this is just showing you, kind of where we expect to go if we average a certain number of cases per day over the next week or two. Did want to, point out that using our local data, if you go back to this inflection point, so really that peak on the red line there, we've had about 13 days of decline from that peak, and then using state level data, we've had about 11 days of decline. So just want to show you the differences between those two data sets. Next slide. And so then this is when can 700 be reached? So using those 6 different lines that I just showed you and the average cases per day, what are those specific dates? So if we use our local data set and we're averaging 0 cases per day, then we could expect to get below 700 by the 30th of January. If we average 7 cases per day using our local data set, we could get there by the 1st of February. Similarly, if we're using the state data set and we're averaging 0 cases per day, we also get there by the 1st of February. And then you can just see how, based on the different projections, it might take us longer just depending on the data set we're looking at and the average number of cases per day that we're expecting to get. So really the earliest that we could expect to get there would be the 30th, but that would, again, that's the best case scenario, assuming we have no cases over the next 2 days. And then, more of a prolonged type of scenario would put us, into the end of the first week in February, assuming that we have still a pretty low number of cases on average per day. And then again, an average of 10 cases per day will not allow us to maintain the 14-day incidence rate under 700. So it's really important that we get to that 8 or 9 case per day average. Next slide. And then just real quick, I just want to touch on these 2 things. I'll fly through these, but these are becoming this a bigger topic of discussion are these COVID variants. And I just wanted to briefly just put it on the board's mind and also the public's mind of just what we're seeing and kind of what we're expecting moving forward. The CDC has been projecting that the UK variant, this one on the screen here, may become the predominant variant in the United States in the middle of the end of March. There are other projections showing that may not be the case, but that's kind of the current thought process coming from the CDC. But with COVID, everything changes, so we'll sort of wait to see what that ends up looking like. But with this new UK variant, we've detected 315 cases of this variant here in the US. 9 have been detected in Colorado. And again, Colorado was the first state to detect the UK variant. What we do know is out of the UK, they found that younger children do appear to be more likely to have infection with the UK variant than with other variants, or at least more noticeable symptoms with the UK variant than with others. Whereas those in an older age group tend to not display as many symptoms or to not be as symptomatic with this new variant. So just wanted to point that out, that is a difference that we're seeing with this new variant, is that it does appear to affect children at a greater level than it would older adults. And then another study that came out just recently showed that there are actually more symptoms associated with this UK variant, particularly looking at cough, fatigue, and a few other symptoms. So they're finding that it overall tends to impact people more greatly than these other variants. So we are currently sending in specimens from Aspen Valley Hospital. Valley View is also sending in specimens to continue to test for this variant. And so we work with CDPHE to learn whenever we may have any suspected cases, and have not received any confirmatory tests at this point for the UK variant. And then last
Josh,
slide.
Sorry, Josh, Greg here. I thought I had understood that we might have one case of the variant here. Is that not correct?
We've had no confirmed cases of the variant at this point, Greg.
Okay, thank you.
Another quick question, if I could, on that topic.
Tori?
Thanks. So, Josh, I was going to ask you how variants are detected. And from what you just said, it sounds like different health facilities may observe a patient that they have questions about and then send in a sample. Is that how new variants are detected?
Yeah, so the symptoms are going to look pretty similar across the different variants at this point. So using symptoms alone, it'd be hard to know if somebody had a different variant. So really, they're trying to test as many specimens as possible. You may have asymptomatic individuals who have the variant. You may have symptomatic individuals who have it. So really, the state is working with several sites around the state to try to get as many samples to the lab as possible. So that's why we began working with AVH and Valley View to get those specimens sent in. It's really hard to do it when you have a lab that does send out testing. So like the microgen sites, for example, those specimens get sent out to a lab in Texas. And so it's really hard for us to get those samples from Texas back to the state lab for sequencing. It's much easier when you have in-house testing at the hospitals, where they can just take the specimen that they already tested and then send it to the state lab.
And then if I could, just one other quick one. I know that the UK variant is one of maybe a half dozen that are showing up around the globe. Is that cause for concern for visitors from those locations?
I think so. Really, I mean, it comes back to the CDC put in a travel ban, not a travel ban. They're asking for individuals who are traveling from international locations to be tested 3 days prior to arrival. So similar thing that we did here in Pickens County, but now they've expanded that to an international type setting. Reason being because of the variants, and they're concerned that if we don't slow it down, then these variants could take hold much more quickly. I think, there is concern that, individuals coming from, places that have high levels of variants, could introduce it into the country. So that's why CDC did impose those restrictions on international travelers.
Thank you, Josh.
Yep. And then last slide real quick, just the two other variants I wanted to just touch on real quick. So there's a South African variant and then a Brazilian variant. As Tori mentioned, there's a lot of other variants out there. There's three, these are kind of the three that are the hottest ones to discuss right now. The South African variant is somewhat similar to the UK variant in a way. It does have several mutations that are different or that cause it to be different. But Pfizer has found that their vaccine is only slightly less effective against key parts of the South African variant, which is good news. Moderna also said that they have found that their vaccine is more effective against the UK strain than the South African strain, but they still found a great efficacy against the South African variant. So that's good news. And what they have found, the US just identified 2 cases here in the US of the South African variant, I believe just yesterday in South Carolina. There are 2 individuals that are not related and had no travel history. So what that tells us is that it's likely already here. We're just not detecting it at great enough levels. That's the South African variant. And then the Brazilian variant, this is probably the one that I'd say experts are most concerned about. They just identified a case in the US up in Minnesota. It was travel related. So an individual that had traveled, I believe, from Brazil. So not entirely unexpected, but now they're just trying to contain it. Moderna has announced that they would likely be working on a new vaccine, which would be tailored at trying to provide like a booster shot or an update to be able to fight these additional variants. So they're still not sure if their vaccine is going to be as effective against the Brazilian variant as other variants, but they are working on a booster shot just in case they find that it isn't as effective. And then there's also some evidence that this Brazilian variant could lead to reinfection with individuals that had other variants. So just another reminder just to continually be on guard, to continue to practice all those same types of mitigation strategies that we've been talking about for months. Even if you've already had COVID, or even if you've had the vaccine, right? Continue just to be vigilant, wear a mask, distance at all times. Just because, we're learning much more about these variants and how they could impact us. So it's best to continue to act with extreme caution moving forward as we learn more about these new variants.
Great, thanks, Josh. You noted that the international travel, they're requesting the testing before travel. I know that CDC is actually considering domestic travel affidavit-like requirements for testing now. And I don't know if that's tied to these variants or not, but it's certainly tied to the concern that we're using every tool they can to slow this down. Is that it? Are we ready to move on to Raleigh and the 5-star program? Looks like we are.
All right. Hi, everyone. My name is Raleigh Backrack. I am a program administrator here at Picken County, and I'll be talking about that 5-star program. So next slide, please. So the 5-star variance program is a voluntary program set up at the county level. And if approved by the state, counties would be able to implement this variance across certain and eligible sectors with oversight from an administrative committee. Depending on where the county falls on the state dial, these businesses would then be able to expand customer capacity while ensuring that the businesses adheres to 5-star specific guidance. Next slide. So what counties are eligible? Counties in blue, yellow, and orange are eligible so long as their incidence, positivity, and hospitalizations all meet their respective dial level threshold. And then as well as incident and percent positivity must be maintained for 7 consecutive days. Next slide, please. So counties in red, like Picken County, are eligible if they had a 2-week sustained decline in incidence and percent positivity under 10% or 10 cumulative days of decline in the previous rolling 14-day period, as well as less than 90% of regional ICU beds in use, in addition to 10 cumulative days of decline in that previous 14-day period for hospitalizations. And levels green and purple are not eligible to apply. Next slide, please. So here's a look at our website that has gone live. It went live yesterday, and this is where you can find program information, link to the application that I will discuss later on a bit, but it went live today, and a link to CDPHE's 5-star qualification report card for us. And this is the report card. This is the resource we'll be referring to determine Pickens County's metrics and the program's eligibility. So today, actually, we did reach that 14 decline in incident rate, and we did pass that positivity rate of 10% or lower. Whereas in regards to those regional ICU beds, we were at 91%. So that is where we unfortunately fail at the moment to implement this program. Next slide, please. So what if cases rise in Pickens County? The state may be able to suspend the program if cases rise or hospitalizations rise. And then the program is automatically suspended if there's more than 90% of the regional ICU beds in capacity. Next slide. So how does this program look at a local level? So after that last Board of Health meeting 2 weeks ago, we reached out to potential administrative committee members, which consisted of local government entities and business organizations, to see who is interested in the program and who is interested in being a part of the committee. Last week, Public Health on the 22nd on Friday, we did submit our application to CDPHE, and we've received confirmation today that there were no revisions needed to be made on that application, and we are awaiting for final approval documents from them now. Today, we have opened up that 5-star application to those eligible sectors, which includes Pickens County restaurants, personal services, and gym and fitness centers. And then next week, application reviews will begin and site inspections will also begin. Restaurants will be the only sector prioritized for inspections and the application review process. And they will also be the only sector to be able to open at that 5-star capacity. Restaurant applications submitted from today through Monday will also be prioritized, and by the 5th, those that are certified can open at a 5-star capacity. And that is obviously dependent on our metrics and that report card. So it was that report card today of that 91% of ICU beds. We may have to look over that timeline again as we will have to see what that looks like for the next few days. And then just in regards to the other two sectors, if our metrics stay on the same trend, once we are able to implement this program, we will then consider opening it up to personal services and gym and fitness centers. And this is, of course, just to make sure our metrics are staying in a decline, or at least just on that same trend. Any questions so far? Okay.
I think, Raleigh, the other clarification is if our current incidence rate continues to trend down and we hit an incidence rate of 700, that might happen, that could happen before Friday, February 5th. And at that point, every business in the county would be able to operate under orange level restrictions. And we can talk, I think there's another chart here that talks about the differences between 5-star businesses and regular businesses, but we can continue to talk about even if this isn't necessary in the short term, what the additional benefits of 5-star are.
And Jordana, could you, this would be an automatic, this would happen automatically, correct? As soon as we hit those numbers, we don't have to have a special meeting to vote on anything, correct?
No, and that's the next agenda item, is to clarify how that's happening, and that's the proposal.
Okay, fine. Thank you. Any other, Brent has a question.
Well, just briefly, this 90% regional ICU rate, do I assume that Denver's not in our region, or they are? Because we do transport a lot to Denver, but we're talking about not including Denver, are we, correct?
From my understanding, I don't believe they're included.
Right. And then my question, and you probably wouldn't have this handy, Raleigh, but I'm not sure who would, but how long have we been close to this 90% number? What's the historical context of this ICU usage? If we have a graph, or has anybody thought about that? In other words, maybe 90% is a real hard number at the moment and going to be very difficult to get much movement out of it.
Yes, I agree. So I actually just received a message. So we were at 78% 2 days ago. So it seems like it's a very fluid number.
Yeah, that's exactly what I was aiming at. Great, thank you very much.
Great,
And
thanks for that clarification.
Raleigh, I can answer the regions. The ICU beds are measured on what's called Regional Emergency Medical and Trauma Service Advisory Council regions. In Colorado, there are 11 regional councils they're called RETACs. We use them in measuring EMS services. They're used in a few fashions, but Pickens County is in the Central Mountain region.
Thanks, John. And if anyone would like to see that report card, we have an updated one for today. I'm happy to share my screen. It's also available on our website, on that 5-star website. If not, I can go ahead and move on.
Let's see, we have a couple questions, Raleigh. Hold on, I see Dr. Kurt and then Jeannie.
Yes, we have so few beds at Aspen Valley Hospital that the small variance in our population can suddenly put us over. So I think that needs to be somewhat taken into account. I would suggest some leniency on the 90% because we just might have been on that for a day or two.
Oh, I
I'm
just
assuming
want
that's a state metric, right?
That is a state metric, and it's not just AVH capacity, it's our regional hospital capacity, as John just described, one of 11 regions across the state.
I just have a question about if we do hit the orange level at 700, would those restaurants in the 5-star program be eligible for yellow?
Right. So if we go over to the next slide, I will cover that. That's a great question. And it's sometimes hard to understand. So I'm happy to take it step by step if you all need. Looking at that data that Josh pointed out, we have seen that decline in incidence rate. However, so if we hit that 700, 700 or greater, let's start from the chart here itself. 700 or greater is that's when businesses that are eligible to apply can apply and be certified and implement that 5-star capacity. So for instance, restaurants who are certified can operate at basically level orange capacities, ensuring there's a 10-foot distance between patrons and that table. Now, if we reach 700 or less, but don't hit that 350 state dial requirement, we would just strictly be operating at level orange. The 5-star program would kind of be put on hold for then, as the state eligibility requirements makes us the county has to fall into those 3 metrics. So having that 350 per 100,000 incident rate or lower. Any questions so far?
Raleigh, I just want to clarify, I know this stuff, that when we talk about being eligible or not eligible for the program, that's really being eligible for these 5-star capacities. So if businesses are certified, they can, and there's no benefit to the capacities, they're still 5-star certified and can, you know, display that metric and have that in their window to know that when it benefits them to have additional capacities, that will come into play.
So Jordana, are you recommending that restaurants all sign up for this as soon as they're able then? Is that right? So when the numbers hit, they'll be ready for it. Is that correct?
It's an optional program, so each business can determine if it's right for them. But some of the advantages are that in these different, you know, when our metrics are in different levels, there are additional capacity benefits afforded to those 5-star businesses. And I think that, you know, Greg, your point of saying if you're interested, actually, if we do hit orange level capacities and it's not a crunch, you know, you're not receiving any benefits right now, it could be a great time to think about the 5-star and apply so that you can become certified and be ready to be afforded those additional capacities when the county is eligible.
And Greg, I think it's important context at the last meeting, when the board established the thresholds for moving in and out of red, and also gave staff direction to quickly pursue the 5-star program. I think the projection was it would take longer than it has and longer than we're currently projecting to reach that 700 threshold, and 5-star was seen as a way to start bringing some capacity back in return for businesses doing some additional measures from a COVID safety perspective. So I think in the immediate, you know, with the potential for our metrics to push us into regular orange kind of capacities as potentially as soon as next week, I think then it shifts to businesses looking a little bit longer term about what the benefits are of the next step down or how to manage the risk should we end up back in the red level.
Thanks for that, John. I think while we're all looking at this and trying to project what's going to happen, as has been said earlier, the assumptions we all make about the way this is going are super important. For instance, if a variant comes back or a variant comes in and we have another spike and we start going back up again, people might have wished that they'd gotten into the 5-star program and were ready to take whatever's coming. So we don't want to rely too heavily on our assumptions.
Another question here, Greg?
Tori.
And maybe John, you could answer this. So what you're showing on this graph is just the 2-week incident rate as a indicator and measure for the movement between levels. Is this the same situation that you described earlier, that according to the state dial, one metric, I don't know how you phrased it, but one metric could be and this is on the decline, not on the increase. So this single metric could be utilized to hold at orange level, or is it still a combination of 2 or 3 that determine you moving to lower levels of restrictions?
I might invite either Jordana or Raleigh to answer that, but I think, you know, I guess let me start to make sure I understand your question, Tori. I think what you're referring to is the metrics on how we move between dial levels. And so the 3 metrics are incidence rate, test positivity, and then hospitalizations. And technically, any one of those going into the red could be cause for the state to move the county to red. In practice, the state had been moving counties to red when one metric had been in for 14 days and another metric went in for any period of time that other metric was in red, which is what we have been talking to the community and the Board of Health about. Obviously, at the board's last meeting, the Board of Health adopted the recommendation of staff to set an incidence rate. If we have an incidence rate per 100,000 on a 2-week average, that's at 700 or greater for 14 days, or we have any of the other 2 metrics also go into red for 14 days and one for any period of time, that the county would move into the red until those metrics came back down. I don't know if that answered your question.
It does, John. I thank you so much for that. At the same time, I'm actually on the state graph that does talk about movement between levels. Yes, I think you just explained it very clearly. It would not be, in my language, a mandate, but there are varying factors that the state looks at in their assessment. Thank you. Thank you.
Great. Let's see, Tori, you have your hand sign is still up. If anybody else has a question, you may just need to yell at me because I can't see everybody at once here. If there are any other questions, otherwise, let's move on. And does that mean we're ready to move on to enforcement? Are we that far ahead, or procedure? Where are we?
Greg, I
Sorry.
think there's just 2 more slides, just kind of.
Oh, you're still on it.
finishing up
Okay,
this.
thanks.
No, yep, no worries. Just one or 2 more slides, Avril, if you don't mind. Thank you. So just a quick overview of the program here. Like I said, we started accepting applications, and we will start reviewing those applications and conducting those inspections next week for restaurants. And then just depending on those metrics and that timeline, it may be adjusted. It's a fluid situation. And next slide. Perfect. And then just an overview. So we do have an administrative committee that will be, that has been developing and implementing this framework here at a local level. So these are just kind of some of their many responsibilities. But, you know, once we start rolling this program out, it will be really turned over to them, meeting once a week to discuss priorities, complaints, violations, actions needed, and then they will be reporting these updates weekly to CDPHE as well as Pickens County Public Health. But that's all I have. Thank you all, and feel free to shoot me any other questions.
Any questions on any of this right now, or should we move on? I'm not seeing it and I'm not hearing yet if you have one. So should we move on, Jordana?
Yeah, you can move the slides along, and I just want to clarify, there's been a question in the community that I've heard come up around 5-star as it relates to restaurants. The question of if a restaurant applies for the 5-star program and get certified, would they be required to continue to have tables spaced at 10 feet and be required to follow all those requirements, even if we move into the orange level? And I just want to make sure that it's clear that that would not be the case. As the county moves to the orange level restrictions, that would apply to all businesses being able to operate under those orange level capacity restrictions, and it wouldn't require anyone who had been certified by 5-star to adhere to that stricter measure.
Great, thanks for that.
Okay, so next on our agenda is to talk about the procedure of how we move to orange level restrictions. Next slide, please. So this was what the board voted to adopt and put into our public health order the last time we met, was that as a county, we would move into those red level restrictions if, again, that incidence rate is above 700 for 14 days, or if one metric is in red for 14 days, and another dial metric goes into red for any period of time. Secondly, the move out of red level restrictions will happen when the incidence rate is below 700 and has been decreasing for 14 days. So if we go to the next slide, we'll focus in on this move out of red level restrictions first, as this is what we're coming up to shortly. The recommendation is, to Greg's question earlier, when we do meet that metric, we see that incidence rate that we're all monitoring, the 14-day incidence rate that we're all monitoring so closely, when it hits under 700, the recommendation is that we would move to the state dial orange levels, the regular orange levels, not the orange plus, any of those additional restrictions, the following day as an administrative function. So as staff, we would be watching that incidence rate and then just have the understanding that that would be a move on the dial that we would make and then communicate out to the sectors as well as the community.
Jordana, quick question on that. I know it's going back into the assumptions, so I'm afraid to even bring it up. But if you see the trend moving, how much warning can you give the community just so that they can be poised to take advantage of the reduction when it comes? So it's not, oh, you can do it now. It's more like, we anticipate you can do this in a day or two. Is that sort of information going to be disseminated so they are prepared for it?
Absolutely, Greg. I think we've started with some of these projections that we've been making, based on what we see, and the closer that we get to the 700 and the more days that go by, the more solid we will be in those projections. So we're definitely thinking about being able to reach out to the community about the status of that incidence rate as it continues to decline.
I'm hoping that we can have some sort of, at least an online or socially distant celebration when we hit the 700 or the 699. That should be a holiday or something.
Okay. Greg,
Okay, sorry.
I might move through some of these. There's a couple steps to questions, and then we'll see if there's any motions that need to be made to operationalize this.
Great.
So the next slide. This, I think one was skipped. If you could go back a slide. So, nope. Yes. Okay. So this slide is the second piece. So when our incidence rate is creeping upwards, and if it hits any of those two criteria in the first couple bullets, the recommendation would be that when those metrics are met, that again, it would be an administrative move to red level restrictions on the state dial on the day 15 of our incidence rate being above 700. And again, Greg, to that point about, warning, the thing about these incidence rates is that we do tend to have warning of when they're moving in a direction and what we can anticipate.
Great, thank you.
Okay, if there's no other questions on that, I'll move to the next slide. That you've seen earlier in the presentation. This is what Josh presented of our incidence rates when we calculate them with state data, and then when we calculate them with local data. And then the various projections at when we might hit that 700 threshold. And just a reminder of what we see is that the state data lag our local data a bit. So when we are having this incidence rate climbing downwards, our local data we anticipate will be able to reach 700 before the state data. So to consider that graph, and then we'll go to the next slide, where this is just another example of how we can continue to be monitoring that sustained decline. Just as we have seen on the state report card, we can monitor when we have had 14 days in a sustained decline. And the question in the next slide, with both of these measures, that would help indicate if we're able to move into the next level. The question is, which metric do we want to be calculating these incidence rates with? So the state dial metrics tend to be lagging of our own local metrics, which mean we would go into the red slower, right? If we're in orange and we're seeing the incidence rate creep up, we would creep up more slowly. But then also when we're coming out of red, going back into less restrictive levels, that move would happen more slowly as well. Using the state dial metrics also aligns with the metrics that are used for other dial level moves. So, if we're solidly in the orange level, to dictate when we move into yellow and other colors, we're required to use the state dial data for movement into the other dial metrics. So thinking about the other potential option is using our local metrics. We know that's a leading indicator, which would mean we're going into the red faster and going into the orange slower. Did I say faster and faster? Go into the red faster and go into the orange faster. Okay, I can read. The local metrics does not align with the other dial movements or the 5-star eligibility. So there's a potential to be more confusing, but I think we've experienced a whole lot of confusion throughout COVID. So just something for us all to consider as we're messaging this to the community and wanting to be as transparent as possible. We wanted to bring this to the Board of Health for a decision about which metrics should we be using in order to operationalize this decision of either going in or coming out of the red.
Are you expecting that conversation right now, Jordana?
Yes.
Okay. I want to open it to questions because I'm still a little foggy on how this will work. And so I want to hear what anyone else might have to say if we have other questions or if we have a need to elaborate. And I'm looking for faces and hands up, but if you have a question. Okay, Jeannie.
Well, I just have a comment. In a pandemic where you have viral transmission, I think it's advantageous to act more quickly than slowly. So working with local metrics where we can go into red sooner might be better for containing viral transmission in our community.
Great, thanks for that. Any other hands up? Dr. Kurt? Still muted.
I agree with the Jeannie that the local metrics make more sense and that we can get out of the red more easily, perhaps between Monday to Friday next week. And we should also be as flexible as possible in getting into the 5-star program as well. And ask staff to notify us immediately when any variant appears among locals.
Thank you. Any other questions, comments?
Aspen would support
Corey.
local data.
Okay. Brent, I'm looking at our other members here. Anybody else I haven't called on lately or?
No, actually, that was my comment was really already answered. Because what I was going to say is why I can see the differences, but why would we do one over the other? And I think that's the fact that it's quicker, the fact that it's local, that's all good. the fact that it might produce some confusion, as Jordana said, well, I think that this whole thing is going to be always going to be confusing. But I think and then as Tori said, the Aspen would support it. I think there's certainly more pluses to using local than not, even if it's got some limitations, and so be it.
Thank you for that, Brent. Jordana, are there any other hidden unintended consequences of this? I just want to make sure we have a thorough understanding. If it's just confusion because the state's on a different track, that I guess, as Brent said, we're kind of used to that anyway. But if there's anything else we should contemplate before we poll a vote on this.
Those were the major points, Greg. So just to be clear, moving between other dial levels, we still need to use the state data, but because the Board of Health has set this incidence rate of 700 as the threshold for Pitkin County to move in and out of red, we can choose what our metrics are to use local data if that's what the board decides.
Okay, I don't see a lot, any other hands up or questions from, oh, we've got Bill. Go ahead.
Yeah, I understand, using local data so we can be a little bit more nimble in the way that we move. But I just think we really need to be following the state data. I think there's so much confusion out there, and nationally, we're getting a lot of comments from people who feel like Pitkin County is closed. So I think it's really important that we follow the state data.
Okay, thanks, Bill. Any other comments on that? Are we ready for a motion? Do we need a motion for this? I think we would.
Just one last question.
More questions, okay.
Brent, we talked about the general incidence rates above 700 for us. Where are they? What's the sampling of other, we've talked about this before, but communities and other civic entities in terms of their threshold?
Jordana?
Where their current incidence rate, or if so Josh, I don't know if you can pull that up quickly, but the incidence rates around the state vary greatly. Everyone else in the state, as has been mentioned, is in the orange level restrictions, regardless of that incidence rate. And I think, Bill, that's maybe what you were alluding to.
Yeah.
So I can pause and pull that up and share it with the group. That would be helpful, or give you a range here.
Yeah, no, that's fine.
Is the question, what are the incidence rates per county across the state?
Yes.
I think that the highest right now is about 1,300, maybe closer to 1,400. And then lower levels are, 100 or so. That's what you're asking, Brett.
Well, yes, but and the trouble is, of course, we have such disparate communities across the state. We have really small, completely rural communities, and we have destination resorts like Aspen and Snowmass, which are really just completely different. So it's hard to.
And Brent, what the state's digging into right now is that uniqueness of especially our resort communities. They just presented to us some additional data about different mobility data. So where we see people going, what kind of activities we see people engaging in, and they found a significant difference between those mobility and where people are going, where they're spending their time, and then visitors, as well as incidence rates and trends in our resort communities across Colorado. As a group, they analyze them versus counties that don't have those resort destinations. And so, we are definitely affected that way. We continue to look for if there's other mitigating efforts that we need to address as a resort community. But what we are seeing is that, the incidence in some of our resort communities is ticking back up.
And I think to both the point Brent is making and that Bill's making, it might be worth talking a little bit how staff arrived at recommending 700 as a threshold for movement. Because that was really, Jordana, I believe, looking at our own capacities in terms of virus containment. So I wonder if you might talk about that a little bit. It wasn't based on a comparison of what other communities are doing so much as our process to contain the virus, I think.
That's it, John. So we were able to learn from our disease investigation team at what incidence rate we have the capacity to still reach out and contact every positive case and then trace the contacts that they've had, which gives us a shot at that box it in strategy, right? So that is the rationale behind how we arrived at that 700 incidence rate of being the level at which we can still use the boxed in strategy and contain it. After it goes beyond that, what we see is that strategy is not as effective, and as we've just experienced, just leads to this exponential increase, where it really requires additional mitigation strategies that clamp things down, allow for less transmission, and then for us to reset back to that level where we can contain it.
Jordana, regarding the, it sounds as if seems to be a pretty clear idea that we move toward local determination here. But to Bill's point, we're still going to have our eyes on what's happening, certainly nationally and statewide, and hopefully that there won't be increased confusion there. But we will have a little bit more autonomy, which perhaps is a good thing. Having tried everything else, is that correct?
I think I don't know if I understand exactly the comment as it relates back. Are you still trying to relate back to the question at hand of whether we use local data or statewide dial data to determine what our incidence rate is for moving in and out of the red level? Right.
That's how I was trying to determine it, just to see if we could, give Bill some assurance that we're not straying too far. I'm still trying to get a grip on this myself. Bill, go ahead.
Yeah, I just think that it seems like the more we learn about this disease, the less we really know. And so we end up making a lot of assumptions. So we are making our best guess, right, at how to box in or control this virus. The whole reason for the shutdown back in March was that we didn't want our hospitals to be overwhelmed. And our hospital has never been in that situation. Dave Rissler was quoted as saying the bottom line is we're not feeling stressed. Our incident rate is high. There's no doubt about that. But our response was also extreme and far reaching. And as I said, the word is out nationally. Pickens County is dangerous. Don't go there. My friends that have rentals, when they get a call, the first question that they're asked is, are you in Pickens County? And if they say yes, the phone goes dead. If they say they're in Eagle County, they're happy to book their accommodations for their family. Elizabeth Carlton, associate professor at the Colorado School of Public Health, said a high rate of testing could be part of the reason why Pickens County is posting higher infection rates than its neighbors. Pickens County is testing at quadruple the rate of Eagle County. Josh Vance said, we ran hundreds of calculations trying to determine what is really the difference here in Pickens County. What is leading to the increase? And we really didn't find anything. So contact tracing is not an exact science. The contact tracers, they look to identify, where the virus was picked up, and most people don't know where they actually got the virus. The state guidelines and our metrics and the governor have put us in the orange, yet we have voluntarily imposed ourselves a rule so that we are going to be in the red, and we are creating tremendous amount of ill will in the community. And to harken back to the George Floyd scenario, we have put our foot on the throat of the restaurant industry, and they can't breathe. I believe the drop in our incident rate, it doesn't have anything to do with closing restaurants, because that data is just coming online now. But I think, as board member Dr. Kurt had suggested very astutely, was that we should be looking at the incident rate on a 7-day level. And that 7-day level is on the metrics that we get. And if we look at that now, we're already below that 350 number. So I think it's really important that we follow the state, that we're not an outlier. So I would make a motion to move Pickens County to the orange, to follow the state guidelines, and that would allow restaurants to open immediately.
Okay, we've we're kind of shifted from the topic at hand a little bit here, but a motion has been made. Is there anybody who would like to second that motion and have further discussion? Okay, I'm not seeing a second to this motion here. I apologize that I don't have the exact terminology in here, how to move forward, but I'm going to table this, or either it's tabled or it dies and could be brought back later. I did want to bring this back around, though. Is that a second coming from you, Tori, or a question?
Well, I want to speak to this point. If I need to second it for further discussion, I would do that. But I want to bring up the points that I wanted to speak to before.
Okay, I'm going to allow you to, I think somebody will have to correct me if I'm wrong in this here. Why don't you just make you don't have to second it. I'm going to say you don't have to second it now, but please make your point.
Thank you. To the mayor's point, and I'm speaking for my council as well as myself here. I think what Billy's really saying is it's not about state data, it's about state guidelines. So while we can use the metrics that are seemingly more timely and more accurate for our usage of our local data, what the mayor's suggesting is following the state guidelines. I think that's kind of a separation of that discussion there. What I've had discussions with my council over the last few days is about setting a date certain for coming out of red. We recognize the trend lines that are going on. We recognize the timing of this is very close. But for us, and similar to Snowmass Council's views, is that we are interested in looking at going back to orange or some level of orange plus that this board feels comfortable with on a date certain, and that date certain would be Monday, February 1. So I am willing to make a motion, but before I get there, I just want to say a few more things about why this council has come to its determination. Number one, this council has been talking about total community health, and that means fighting both the virus as well as the impacts of the restrictions on our total community health. And we want to fight both of those. We recognize that this past 2 weeks of closures, we've seen an amazing trend downward of our incident rate. And if it were at this point 2 weeks ago, we would probably not have put ourselves into the red level restrictions that we did. We see other factors in our community. We've had some great outreach and community support from people like Meridian Jewelers and Robin and Kenny Smith. the YPN at Aspen, and the Aspen Board of Realtors, who set up a program just recently with the Aspen Cookbook. I hope many of you know about this. I hope some of you have bought it and shared it with others. The latest numbers from them are that they've had over 500 just restaurant employees applying for their ability for relief. We see that as a trend in the wrong direction that may be enhanced by full closures that we've been in. We also recognize that Pickens County has really put forth their best efforts through the CARES Act to make business relief available. But what we are most concerned about is the individuals, our residents, our visitors, and those that work here. So with that, as I said, my conversations with my council have been talking about a date certain of Monday, February 1st for opening. We would be most comfortable with an orange level with some added restrictions, as we anticipate that we were going to hit that 700 level as soon as mid next week. But without that, we would feel comfortable, and we would advocate for, as a council, for February 1st, Monday, to go back to a orange level of restrictions. And if there were any modifications to that, one modification that could be made would be, and we didn't see it in the orange level, there is a 10 o'clock curfew, but for a last call, I believe, but we were thinking of an 11 o'clock actual business curfew. So we do see the opportunity and our trends and our total community health to benefit from a restrictive reopening of some indoor capacity. I can make that in a motion if you'd prefer, but I also want to open that up for conversation.
Thanks, Tori. I think I've already got a motion on the table. I think that if this is an appropriate time, the conversation, I want to bring us back around to the question that was at hand. And I apologize, I'm not sure where we were, if we had a motion for that or not. Maybe we
Greg,
didn't.
I don't think you
John.
had a second for Bill's motion.
Right, I didn't,
So for lack of a second, that motion would die. And I think Tori has proposed a topic for discussion, but has not yet made a motion.
thank you, John. That sounds right to me as well. Okay, I think that this is taking us enough tangentially. These are very good points, and they're conversations that need to be had. But I also want to get us back on track, and we can make room to have these conversations. But I want to take this back to Jordana. If you have a response or you have a recommendation regarding the question that we were discussing earlier, which is, go ahead.
So you're asking to go back to this, what we were looking for guidance from the Board of Health around is whether to
Yes.
use local data or state level data to determine our instance rate, and when we would qualify.
Yes, I want to finish that conversation before we move on to these other topics, which are certainly important. But I just want it just to get the business done.
So I've heard that there's preference for using local data. I don't know if we need a formal motion to do that, John, or if that's just the guidance from the board.
At this point, I think it would be good just to make sure you hear the voices from all board members, because there was some disagreement, to go ahead and get a motion and a vote on that, so we know which data, the community knows which data. And then following that, Tori, I would recommend maybe that you put what you suggested into a motion for the purpose of discussion.
Okay, yeah, that's how I'd like to conduct this. So I would love to hear from the rest of the board on what Jordana brought up, and then we'll move on. And Tori can put that into a motion, but I'd like to have that conversation first. Thank you. Does anybody have, Tom, Dr. Kurt, I saw your hand up, but I wasn't, okay, you're on mute.
I'd like to comment on this because my heart has gone out to the people in the restaurant industry. And I've seen this fall, however, in the data, which makes us honor the local data over the state data. And as I pointed out at the last meeting, asking for a 7-day moving average, which is used by CDC and Johns Hopkins now. And we're posting that on the daily data. We can use both the 14-day moving average and the 7-day moving average and the local and go off the red as soon as possible next week that the 700 falls, that we fall below the 700, in my opinion.
Great, thank you. I see Brent.
Yeah, just to Dr. Kurt's point, I think that's pretty huge, the 7 versus 14 days. And I think if other knowledgeable entities use the 7-day average, perhaps that should be discussed. And then the other thing I'd say in terms of the incident rate, and correct me if I'm wrong, but it is in part, of course, affected by the amount of testing. But on the other hand, if you have a higher incident rate, it means you've got the disease there. So if nobody's fishing in a pond, you don't know how much fish is in there, right? But if you have 50 fishermen and everybody's catching fish, then you can make the assumption you got a lot of fish in that pond. So am I wrong in that? Yes, you can lay it off to some degree on testing, but at the same, and that's true anywhere, but at the same time, it shows that there is a real pool of disease out there.
Thanks. And Greg, can I just make a quick clarification on
Jordana,
this
sure.
question of the 7-day incidence rate versus 14-day? You know, when folks are looking at that on the chart, you'll notice that when we're looking at a 7-day incidence rate, it seems to be about half of our 14-day incidence rate, or a lot lower. And so that's because of how it's calculated. So a 14-day incidence rate takes all of the cases that have happened in the past 14 days and looks at what that rate is per 100,000 people. A 7-day incidence rate takes all of the cases that have occurred in the past 7 days and looks at that as a rate per 100,000 people. And so there's different advantages to both. They both tell us different things. So the 14-day incidence rate is going to be a lot smoother of a line. It's not as quick to move. The 7-day rate is a little bit more elastic. And if we were looking at, and the state is using the 14-day incidence rate on their dial and their metrics, that's where they've set these incidence rates of 350 for entering into the red level and various levels. If you're looking at a 7-day incidence rate, you would have to take all of the metrics that have been set and divide them in half, because you're only looking at half as long of a period of time.
I'm not suggesting that we drop either one, but to look at both, recognizing that the 14-day has a so-called heavy tail.
Got it. Okay.
And Greg, if I can add one point real quick as well, we did run a regression analysis looking at testing versus incidence rate in every single county across the state. And there was not a strong correlation. There were some counties that do very little testing and had very high incidence rates. There are some counties who would do a lot of testing and had very low incidence rates. So we didn't find a great correlation there. I mean, there was some, right, as we'd expect that there would be some, but there's not a great correlation. So I wouldn't use, rate of testing as a metric to really understand prevalence in the community.
Thanks, Josh. Okay. What I'd like to do, if we don't see any other hands up for questions, is entertain a motion regarding the question on the table. Does anybody have the stomach to do that? I see it looks like a motion from Dr. Kurt. And is that a second or a question from Jeannie?
It's a second to use the local data.
Okay, so we have a motion to use local data and a second. Further discussion. I'm not seeing hands up. I'm going to call the question. All in favor of using this local data? if I could, I'm seeing 4 hands up. I think I have a 4. If I include my own, that okay, we've got 5. Do we need a roll call on that, or are you okay, Suzuho or Lindsay or whomever?
Let's clarify, Greg, because I think I saw Tori, Greg, Tom,
Jeannie,
Jeannie,
Tom,
and Linda and Brent.
and Brent and Linda. Right, thank you. Okay, we've decided to do that. What next do you need from us, Jordana, before we just want to keep us on track? I'm not going to throw out the previous conversations, but I just want to make sure I know where we are.
That was the decision that we needed from the board.
Okay, Tori, did you have your hand up?
Yeah, I would like the board to entertain a motion. Is this, now should be the appropriate time? I'd like to make that motion.
Hold on just a moment. I'm just wondering, for procedural reasons, do we need to make sure we have a correct count of people opposing the last motion?
Great, Greg. Yeah, we just need nays and abstentions.
Okay, I'm sorry about that. Regarding nays, I think, what were the nays on that going local? I see 1 from Bill. Abstentions? No abstentions. Tori, were you, I don't know where you were.
I voted for utilizing local
You
data.
did, okay, all right.
Yes,
So
but
all right.
my clarification there was that, there's a separation. Using local data is one question there. The other was about the state guidelines, and I believe we're going to be using state guidelines sooner than later, but yes, for using local data.
Got it, okay. Just wanted to make sure that's clear. So Suzuho, do you have what you need there?
Yeah, we're good. Thanks, Greg.
Great, okay, thank you. All right, now, I want to bring it back to Tori. You were going to make a
Thank you.
motion.
Yeah, I'd like to make a motion for the Board of Health to direct the Pickens County Public Health Director to prepare a public health order effective Monday, February 1st, that would place Pickens County in orange level restrictions. And I will go ahead and add until we reach our 700 level threshold to go to full orange, we would support the addition of 1+, which is to institute the 11 p.m. curfew.
I'm looking for a second to that. I do want to have a conversation about it, so we're going to talk about it. But I'm looking for a second, and
I'll second.
I see a second from Bill. Okay, discussion on this. Patty has her hand up.
Yeah, I've tried to be quiet this whole meeting, but since the Board of County Commissioners has not had the opportunity to discuss this is pretty significant. I've been receiving text messages back and forth with Francie Jacober, who seems to be on the same page with Tori and Bill. And so am I. So Greg, it's going to be a tough one since you don't really know where the BOCC stands. I think Snowmass and the city of Aspen are pretty clear. For the rest of the board members, it's easier to make your decision, but for those elected officials on this board, they really need to vote with the consensus of the boards that they represent. So, so Greg, I don't know how you want to approach this, but I just sent Francie another thing confirming, and she says, yes, pretty much she thinks it's a good idea. I just want to make sure that Bill Madsen has a consensus from his board too, because I don't want it to come back then and have it be a disagreement between the elected boards. So I'm just giving you my position. I'm okay with a 10 o'clock curfew. 11 o'clock would be great, but I'm okay with 10 as far as setting Monday as a date certain for the restaurants to start gearing up. I think that would be great. I think we need to see if we can get them back in at least 25% with a 10-foot separation of tables. I think that would be a good way to go. Still starting out on the conservative edge. Thank you for the opportunity to speak.
Right. Thank you, Patty. I know that I heard from Kelly that certainly I think it's splitting the same way our board was split, and it was basically 3-2 previously, and I'm going to assume this one would go the same way. I have not heard from Steve, but we'll try to check in with him. But meanwhile, I want to hear from others on the board. I'm uncomfortable with the way this is going, and I think in any event, if we're going to make changes like this, my personal feeling is that they need to be referred back to staff, public health staff, because we need to analyze it. As Patty said, it would probably have to go back to our board for discussion as well. So I don't think this should happen today. I really don't. But I also want to hear what other people think.
Yeah, I've got a question, Greg.
Yeah, Brent?
Yeah, I agree with you. I think a little more referring that back to staff briefly would be a great idea. But secondly, what happens if things go against us? We have this date certain, and we're talking date certain, February 1st and February 3rd, we start moving above or in a very negative fashion. What then? Do we call a special meeting and undo it? Or do we make some sort of caveat within the order? Make it not predicted, but predicated on certain other metrics staying in line? I mean, I'm not sure what we accomplished by doing that, but anyway, that's just my thinking.
Thank you, Brent. Thanks for that.
Yeah.
Patty?
Yeah, Jordana was pretty clear on that before with her, where the direction she was going. If we were to go to Orange Plus or Orange because we met the metrics, midweek or whatever, she said it would be administrative to go to red. And that's what she said there. It would just be a matter of, yeah, if we popped back up again, obviously we'd go back into the red restrictions. And the same thing, we were hoping that could be once we get to the orange level, we could pop back to the orange level without having to have another meeting. But, we can always have special meetings. We always do. We can have a one topic special meeting. Yeah, so, it's too late to notice a meeting for tomorrow because we're already at 3 something, but, it's a Friday night. We have nothing else to do. We could always spend a Friday night on lights together and have a special meeting tomorrow after being able to run this by our boards and by staff. We need to be flexible in these decisions.
Thanks, Patty. I see Bill has his hand up again.
Yeah, the majority of the Snowmass Town Council is anxious to get restaurants open again, just for clarification there.
Thanks, Bill. I think the entire community is anxious to get the restaurants open. How we do it is the question. I'm looking to my board for other voices. Do we have other voices who want to weigh in here? Dr. Kurt.
I feel uncomfortable with a 11 o'clock closure because going from 10 to 11, that's more likely to be involved with drinking, which gets involved in social activities, which probably was going to increase the rate of cases. So I'm comfortable with the 10 o'clock closing.
Okay, thank you. And I see Linda and then Brent.
I agree with Dr. Kurt. I think the 10 o'clock closure makes more sense to me. I think we'll have more incidents with increasing drinking and increasing socialization after 10 o'clock. And I think there's a fluidity to all of this, and Jordana has clearly demarcated that fluidity as far as going into the red zone or the orange zone or whatever. So I agree with the proposal that Tori proposed, with the exception of the 11 o'clock closure.
Just to be clear on that, Linda, you proposed a date certain, February 1st, as we go to February 1st, regardless of what happens between now and then?
Yes, unless of course tomorrow the numbers are exceptionally high or whatever, or over the weekend. Yeah.
No, I think that if we were to take that up, we wouldn't have the choice of changing it unless we had a special meeting. Is that correct? If we say we're going to open up on February 1st, and if that's the decision we make today, we'd have to have another meeting to decide to do something different. Is that correct? I'm looking to Jordana or John.
Yes.
I think I'm getting a yes.
And we could do that.
And I would just like to also clarify that as it stands, with the previous vote of how the current public health order reads, is that when we do hit that 700 level of incidence of 700, the next day we would automatically be moved to orange. Linda, to your point of whether that comes before February 1st or after February 1st, and there's no curfew associated with the orange, the regular orange level, which just want to clarify those points.
Thank you,
Thank you.
Jordana.
Thank you for that.
Hey,
Corey?
Greg, I am amenable to amending my motion as was suggested by other board members, so I'd be happy to do that.
So you're amending it that a date certain of February 1st with a closure remaining at 10 or at 10. That's what it was.
Yes.
Okay, now by making it a date certain, we're kind of locking ourselves into something that could be handled administratively if we didn't. Is that correct, Jordana? I think that's a yes. I would love to, I see Brent's hand up. Sorry, Brent, didn't get back to you.
I just wanted to say that we haven't talked about it yet. Maybe we will in enforcement, but you know, all of this, whatever we do, compliance and kind of goes hand in hand with enforcement, but it's what we're trying to do is change social behavior. And there's been report after report after report, you know, private parties and such. And I don't know if it's true or not, but I do think that anything we can do to strengthen compliance and enforcement, and as I mentioned before, in Europe, and I don't know whether it's in Austria or maybe the Czech Republic, but it's somewhere, I think it's Central Europe, the fines are crazy high. I mean, they take this whole thing seriously. If you don't have a mask on, you're going to be sorry. And if you're in a restaurant that is improperly opened, and I'm sure of this, I think the fine was either 25 or 35,000 euros to the restaurant and 1,500 euros per participant. So they, you know, now I don't know how widely that is applied, but they take it super seriously and super aggressively. So with all this is great, but we still need to make sure that, you know, people don't relax, that they don't see this as an easing, of which it is, of the requirements, but they understand that, you know, we're trying to split the needle here. And
Thanks for that, Brent. We're gonna talk about enforcement next if we can get there. I want to finish this. Jeannie, I would love to hear what you have to say, and I'm going to solicit this from others as well.
Yes, I agree with you, Greg. I don't want to set a certain date because who knows what will happen, as well as there have been a lot of businesses other than restaurants that have been in the red, and we're not addressing their concerns either. So I would like us all to go into orange when it's time, and 700 is very generous as a state level for red is 350. And we want to get the incidence rates down. We need to get our kids back in school. We need to get this virus out of our community so people will stop being exposed. The restaurants are not the only businesses, and I love restaurants. I want them to open. I've been supporting them through gift certificates, but you know, people who have concerts or gyms, they have not been able to operate at all. And our high school has been remote for weeks. We need to get this down because we need our kids back in school. They're getting D's and F's, and some kids cannot learn remotely. So I would like to stick with the current public health order.
Thank you, Jeannie. I'm just looking to see if anybody else on our board has a comment. I'm going to need help getting us back to where we were. We had a motion on the table and a second. We're open for a discussion. I think if it's time, I will call the question, but I do want to hear a rephrasing of the motion before we do. And I can't.
I'm glad to do it. Yeah,
Thanks.
glad to do it. I'm asking a motion to have the Board of Health direct the Pickens County Public Health Director to prepare a public health order that would be effective Monday, February 1st. That puts us back into orange level restrictions with an additional plus of a 10 o'clock business service curfew.
So Greg, I think it'd be worth the board talking about additional clarification. I don't understand what this means for the whole metric discussion we just had, moving in and out of red. I mean, is really what's being proposed here changing all of that? Because I don't know how we act as staff now.
I would say that I think I'm going to vote against this proposal. I'll tell you up front, because I think it has to be evaluated first. So just my 2 cents for now. And Bill?
Yeah, I mean, I will be the first one in line to vote against it if we have 2 indicators that put us into the red, but we don't. We have 2 indicators in the yellow, and our incident rate is dropping. And as I said before, if we use the 7-day incident rate, as Dr. Kurt has suggested, we're already below 350. So if we just follow the state guidelines, we're going to be fine.
Okay, thanks, Bill. All right, I'm waiting to hear back from, I heard from Kelly Curry. I've not heard from Steve. So I'm feeling pretty rushed here on this, and I have to say I'm not comfortable with it. So you know where I'm going to stand on this. I'm going to call the question. All in favor of this motion, say aye. Give me a hands up.
Sorry to interrupt with Tori's motion. We'll just need a second to start this.
Oh, didn't we had a second from Tori, or did we have, sorry, we had a second from Bill. I think Bill seconded. Is that right, Bill?
Yes, I was the second.
Okay, thanks, Suzanne. So calling the question, all in favor. I see 2 yays from
Aye.
Bill and Tori, nays. I've got 4 or 5 nays here. Thank you. The question does not pass. All right, we're going to go back and I need to get us back on track.
Quick
Jordana?
question then.
Yeah.
I'm assuming, I think Jordana said next day. So if we hit 700 Sunday, we'll be in full orange on Monday. If we hit 700 on Monday, we'll be in full orange on Tuesday. All right. Well,
Right.
I just want to point out for board members that there is no curfew associated with the orange. So I think the motion that was just made was actually on a conservative and like I said, a balanced position. So I thank you for your consideration.
Thank you. Thank you, Tori, and thanks for that comment. I think it makes a lot of sense to examine that, is what I can say. I think at this point, I'm not able to move that quickly. But I think we've also got a good solution here, and we're on track. If I could get moving on, where do we go from here? Do we go to enforcement now? Are we ready to move on to the enforcement conversation? Jordana? Or that would be Kurt Dahl?
Yeah. Okay, thanks, Greg. Thanks, Jordana. Afternoon, everyone. I will give a quick update. I know we're already past time. We wanted to talk through a little bit the enforcement. We've brought this up a couple of times. We've heard the community talk about this, and we've heard the board talk about it. And as we walked through, our current process for enforcement is somewhat difficult and complex in terms of enforcing on individuals and businesses. As an example, Karen Kinnaman, when she was director, we had an enforcement piece that took 6 months before we actually came to resolution. So we've been asking these questions, had an opportunity. Jordana, John Peacock, and I had a conversation with Sheriff DeSalvo about enforcement after we had moved to the red metric. He had expressed interest in looking at where we could coordinate efforts. And then a week ago, we had a conversation with the larger law enforcement officials throughout the valley with Aspen Police, Snowmass Police, DeSalvo, the Sheriff's Office, to talk about opportunities for enforcement. And a couple of things that staff listed out as places we were interested or had been hearing complaints to look at enforcement procedures were around either violations of quarantine and isolation orders, the personal gatherings piece, which comes up an awful lot, mask usage, the traveler affidavit, and then the lodging piece with only having one household with lodging reservations or staying. So in discussing with the sheriff's office and the law enforcement officials last week, what came up was really they felt like their role it was really in the moment was the piece that I wrote down. So they were thinking about where they could make a difference in violations that are occurring at that time. The piece that really gets brought up with that then is personal gatherings that we continue to talk about, which I think we're really happy to have some potential for some enforcement there. One of the other things that the law enforcement officials did talk about was wanting to continue with the same route that we do with any other enforcement of any other rules, and really having the discretion at the hands of the officer that is on scene in terms of whether or not they're providing education and really gaining compliance. And it's that idea of gaining compliance over just automatically ticketing. So I think, the intent is to start with education and gaining compliance. And then if we need to go to ticketing, then there may be a possibility with that. But it really is at the discretion of the officer on scene at the time. So I think there was an article in the paper that was talking with that. So we're now working on coordinating some of these pieces on how we get information to them when we receive information about a personal gathering, utilizing the non-dispatch or non-emergency dispatch number that we have up on the screen. And then after that discussion, staff then talked about we still continue to get complaints that are really after the fact. And I think there's still a desire with staff to look at how do we take some enforcement action there. So we have a meeting tomorrow with our attorney's office and with Gary Tenenbaum with Open Space and Trails. They have rangers that enforce rules that aren't law enforcement officials. I've talked a little bit with our attorney's office about that. There may be some comparable ideas with them, but it's also, as they pointed out, they're enforcing rules that are on property that's owned by Pickens County already. So I think there will be some differences in how we approach it. But I think some of the important questions that we have that Gary may be able to help us with have more to do with triaging complaints, if you will. How do we sort out what complaints are valid, what's not, understanding the amount of evidence that we need. So, tomorrow really is going to be this larger conversation with the attorney's office and Gary to talk through, some of our process. Are there opportunities to streamline it? How do we triage the complaints, the evidence piece, if we're taking things to court? Do we need to make changes to the public health order in order to take enforcement on some of these after-fact pieces? And again, what we have right now in place is really around businesses. So we have things like a notice of violation or a cease and desist order that go out. But if we're dealing with an event after the fact and we don't get that opportunity, what do we need to consider there in terms of actually then writing out some type of violation? So that's where we are. Hopefully we'll have a little bit more of an update after that. Greg, if there's any questions I can.
Thanks, Kurt. I appreciate it, and I certainly would approve. I don't know if you need thumbs up or anything, but I certainly approve of the conversations ongoing and developing these capacities going forward. And now's the time to do it. So if there are any other questions, the question I had is regarding enforcement of say somebody comes here, they ignore the affidavit, they don't bother getting tested, they fly back to town or they fly to town and they turn out to be sick. They get contact traced and they have COVID. Is there a mechanism in place for enforcement of the COVID of that affidavit violation that we have in place? And has that ever been enforced, and is it enforceable? I don't want to ask that second part of that question, but the question regarding enforcement is, does the affidavit have teeth? Because I've heard of people who've made those, trips and come back and didn't bother to test and then got people sick. Is
Right.
there any recourse for us?
Right. Well, that's one of the pieces that we'll talk about tomorrow. When we initially adopted it, there was an urgency to get that in place before the Christmas rush. So we didn't put teeth in that intentionally. But we've talked through the process, and that's part of what we continue to come back to is when we do disease investigation, that's a likely opportunity to identify that. And then the question that really comes up, and that's where the discussion tomorrow is going to come in place. Can we then, is that evidence enough? What evidence do we need to prove that so that if and when we do go to court, that will hold up in court? And then B, the real question around not having a notice of violation or a cease and desist or any kind of opportunity for somebody, does that matter? And it may not. But I think we want to make sure we're clear that, we're now talking about a violation that's occurred in the past, and we want to make sure we got all that in place before we just start writing tickets there. But I think that's certainly conceptually one of the things we're thinking.
Well, great. That answers my question that you'll be talking about that. Does anyone else have a comment or question on this? I do want to keep us moving, but I want to make sure everyone has a chance to weigh in here. I do want to applaud the law enforcement for stepping up now. I don't see any questions. So if you're done, Kurt, or somebody said, Jordana.
Just one clarifying comment is that the traveler affidavit is currently required in the public health order. So that is the teeth, that if you do not complete one upon coming to Pickens County, if you if you're staying overnight and you've been out of Pickens County for more than 10 nights, there is the teeth of the public health order. I think what Kurt's really referring to is what's the process by which we would identify people and move them through that process of consequences that are already outlined in the public health order.
Great. Thank you for that clarification, and we'll get a report, I assume, at the next meeting. Thank you. I apologize that we're so far behind, but we did have a pretty robust conversation there. Suzuho, you're up for data dashboard update next, and I'm hoping that that's we move hastily.
Keep it brief.
Not too hastily.
Yeah, we'll try and go through this as quickly as possible. I just wanted to start the conversation by reminding you all that at the last Board of Health meeting, there is a request to make our data that's in the daily updates more accessible to our community to ensure there's equity in that access. So I wanted to introduce you all to John Anderson, who's our data analyst who's been managing all of this work. And he's going to talk through some of the updates that are coming with our dashboard to make that happen.
Sure, and thanks Suzuho for the introduction, and good afternoon, everybody. So I just want to talk through some of our plans for presenting the data requested, and just note that we've reached out to our partners internally, so other people from other departments, a lot of people who manage comments from the public, and our own internal staff are generating a lot of this data. So we're really presenting sort of a collaborative plan here. So we try to get as many perspectives as we can in making these decisions. I'd also like to point out, because it's so relevant from the recent discussion we just had earlier in the meeting, this is mostly local data we're talking about here. The only exceptions are some of the data we're presenting on the state dial page, or where we're presenting a record of the state indicator. So what I'm talking about here is that local data that underlies our existing dashboards and some of our in that daily summary. So our objectives for this is to provide a timely and centralized location for data that's accessible to as many people as possible in our community. And we're providing the key indicators that we use in public health for our monitoring, our decision-making, and public presentations. And we're planning to launch these new dashboards in our ArcGIS software, which gives us some advantages. It's powerful for centralization. It gives us some control over the updates, which improves our data quality if we can get that timing synced up. Everybody's using the same data, everybody's seeing the same indicator at the same time. And just a note that this is the same software that Johns Hopkins University used for their popular COVID-19 dashboard. Next slide, please. So the commitments we're looking to continue mostly is providing bilingual access in English and Spanish to be sure we have that equity piece met, as best we can, present demographics that show that we're monitoring for those inequities during the pandemic. We're also looking to provide sufficient narrative in our data presentation in these dashboards to allow the public to interpret the numbers as best as they can, with as much knowledge as they have, as we have behind what we're doing in our interpretation. We're also looking for mobile-friendly view. Over 50% of our views are mobile, which really is really what we're trying to do with these dashboards. They're more dynamic, they adjust to different screens. And the idea is to replace the need for that PDF in our email update because it is not very mobile friendly. So we want to make sure we address that. Next slide, please. So these are the data categories that we're planning to present, and this represents well over 100 different indicators. So I've kind of grouped these together to give you an idea and make sure the data we're presenting is what's expected from the board. We're looking at case data, so picking cases, which is cases among our residents. These are people that test positive for COVID-19. This is both 14-day, 7-day incidences and counts. I just wanted to highlight that because that's been a topic of discussion today. This would include detailed breakdown of our out of jurisdiction cases, information about outbreaks, the demographics among people who have tested positive, information specific to our children in the community, information about community spread, which is those unknown sources when we can't trace that through disease investigation, information about contacts, and then some of those case metrics that are specific for protect our neighbor metrics, which are that green level when we get to that point. We'll continue to present the same hospital data as we have in the matrix, so that wouldn't change. Next slide, please. We're also planning to launch a more detailed information about our tests, so that would include our percent positivity, which is another key indicator. Again, both 14-day and 7-day averages for that. Also some information about demographics, total tests, and another key indicator for protect our neighbors, which is that testing turnaround time. And that's another key indicator for tracking, our ability to box it in. Some new data we're hoping to present soon is data on the vaccination. We're still pulling some of that together, but we definitely want to present information about who's fully immunized and provide the public some information about how that's going by dose and some demographics. And then the final piece here is the consumer and employee protections. Some of that information is also sent around in an email on a PDF. And so we're hoping to move that also to a dashboard to give the public an idea of how we're enforcing some of our public health order requirements. Next slide. So that's the overview. We're planning, our timeline for this is to meet with key partners through early February to make sure we're getting the right input and presenting the data in a way that everybody is, appreciates and is useful. Our rollout will start this Tuesday with a press release on Monday outlining that first rollout. And then we continue to roll out data in different phases and hopefully have all the data I've mentioned here up by early to mid-March. Next slide. So here's an example of the dashboard we're planning to launch on Tuesday to give you an idea of what that may look like. And, we're still cleaning this up, but just want to give you a visual of where we're at. And with that, I will open it up for questions.
Greg? It's Anne. I've got a question. Thanks. Thanks, John. Yeah, I look forward to seeing that. Are you going to try and track the original COVID and variants in your data?
Yeah, I think so. We haven't had that discussion yet, so I think that's something we would definitely consider. It'll kind of depend on how timely we can get that data, how available that data will be from the state. I could defer maybe to Josh if he has more information on how we might trace the variants. I think we said it is timely and useful and will help us kind of in our decision making.
Well, as they become more prevalent, I'm sure people will be interested in the instances of it in Pitkin County. Thanks.
Yeah, definitely. I'll definitely note that too, so we can continue that in our conversation moving forward.
I'm looking for other questions. My comment, I think, would be what I'm most interested in is simplicity. I like to look at it at a glance and move on. And my reaction to the current dashboards have been, oh God, I'm gonna have to sit down and dig in deep here. When really what I want to know is probably much simpler than that. Which general direction are we headed, for instance? And so I'm going to advocate for the at a glance simplicity indicator. It's great to have everything else in the background and be able to dig in if you're inclined, but I know a lot of people are overwhelmed by the amount of information, and I also know it's hard to choose what's important. So I know it's a tough job, but simplicity, I think the graphics on that glance I just had looked pretty good, and it looks like you're working toward creating a simpler, better way of communicating. But I think that's essential to make it useful. I found myself using it less and less because it was so complicated. I see Brent has a question.
Well, just, I was going to say that when you get a bunch of graphs like that, I feel the same way Greg does. It's a challenge, and sometimes they look to be conflicting, and you really don't know. What would always be helpful, I think, is a very short narrative. Things are getting better, things are getting worse. Here's what to look for, wear your mask, whatever. But just a nice little paragraph that if someone couldn't interpret all the data, at least they see things are heading in the right direction. Incident rate is down, good job, keep up the good work, stay tough, etc. Thanks.
That's a great suggestion, Brent. It's kind of like the weatherman. He's got a lot of data to show his meteorological data and how he's made his decision, but he encapsulates it into a sentence or two. And that might be, that might be very useful. But thank you for that. Any other questions on this? If not, we're going to Bill, and then Tom, Kurt.
Yeah, I think the dashboard or the dial that we have is great. It's very simple. It has 3 lines that you basically follow. But my question is really in regard to the daily reports that we get that are not made public. And I'm just curious to know why they're not made public.
Yeah, so I mean, I think from our standpoint, I think that originally there was a little different intention for those originally, but I think they're pretty, like you said, that we're in the place we're at. People know about that, and they want to see that data. So I think so we evaluated just doing that, and we came to the conclusion that because of the format, a dashboard would be better. That would give people a little more interactive experience. Some people find the PDF overwhelming, kind of the way that Greg was just talking about simplicity. Some people find that document as it's on its own kind of challenging to get through. So I think from our standpoint, we feel like the dashboards give us an opportunity to highlight those key indicators, keep things simple, but then also add some tabs in ways that if people who want to dive deeper, they can do that. So that's kind of our goal moving forward. So getting all that information from that, relevant information from that report out in front of the public in one place so that staff can use that for their data needs. The public can use that. We're all using that same thing. There's not another version of something circulating around in a smaller group. So, really we feel like that brings equity back to the forefront. We're letting everybody see about the same amount of data, and they can explore it as they see fit.
Thanks, John. Dr. Kurt?
Sorry, John. Oh, I'm sorry.
Go ahead, John.
I just note that while that report isn't on our website, we do distribute it pretty broadly. So, members of the press are getting it, a lot of members of the community, I think you all as elected officials. And so we just haven't put on the website for all the reasons that John was describing. So it's not a embargoed report or anything like that.
Thanks, John. Dr. Kurt, and then Tori.
I'm concerned about 2 things. Number one, security of private information that might possibly be tied in and accessible. And number 2, some kind of troublemaker coming into the site and then hijacking our information or charging a huge amount to unfreeze it. So those precautions with some kind of a security firm, I think, are important.
Sure. Yeah. So we're definitely taking a lot of steps to make sure that doesn't occur. We're aggregating our data, so underneath these dashboards, there won't be any of that information available. So yeah, we're taking a lot of steps to make sure that doesn't happen. I think Kathy's on the line here too, if they want to add any information about that.
Hi, Kathy, you're muted.
Oops, sorry about that. My name is Kathy Lutzganon. I'm the county risk manager. And I do want to let you know, we recently just completed a forensic scan of all of our systems and using a third-party company that actually our cyber insurance carrier recommended. And the good news is they found nothing. They dug and dug and dug and found no vulnerabilities in our systems. So that's really, really good news. And the county's very, very proud of the fact that our systems are as secure as they are. So I think that's the good news. Certainly cyber hijacking and ransomware or demands for ransom because websites are being held hostage or running rampant throughout the United States. The county does have insurance if God forbid that ever were to happen. But at least it seems as though we're making every step that we are taking every step that we can take to prevent that. And, you know, having an outside firm just confirm for us that we're doing all the right things certainly made me feel a lot better.
Thank you, Kathy. Nice to meet you. I think we had another, was Tori, you were next?
Yeah, mine's very brief. It's not actually about the new format and dashboard, but just a question about yesterday's and the day before. I think I saw the same numbers reported for AVH over the last 2 days. I didn't see a change in those numbers, and I just wanted to know if that was correct, that we didn't get updated information. Was that the data from the day before, and will that be updated for us?
Are you talking about the testing data for AVH?
Hospital data.
So we have kind of two sources. We have the matrix that we update. You know, AVH gives us, you know, information about updating. That's the levels in the matrix from green, red, and yellow. And then we also have the testing positivity. And I would just kind of indicate that positivity test where we show total tests and % positives, that is updated on a weekly basis. And actually, Andrew Shoemaker's on the line here too. He can give further information if you need.
Yeah, I'm referring to the line that has the new patients admitted on a daily basis, ICU beds, total beds, those numbers.
Oh, so you're talking about the daily summary here,
yeah.
The PDF?
Yeah.
I can't speak to that directly right now, but I can certainly look into that.
Thanks, I'd be interested in those.
Sure.
So the question is, how often is that updated, and are we seeing it fairly in real time? Is that the question?
I can answer that, John.
Yeah, thank you,
So
Josh.
Tori, we update that whenever we receive the report from the hospital. Sometimes there's a lag if we're, don't get to the email in time before the report goes out. So it was just updated, I think right after the report went out. So it'll be updated tomorrow. So apologies for that not being updated.
Got it. I don't know if there's an opportunity to put just a timestamp on it or something, so we know how old the data is, if that would be helpful, just so we know if we're looking at, say, ICU beds, for instance, or whatever Tori was most interested in. Not sure if a timestamp might be valuable there. Okay, I want to move this along. Are you finished with this presentation, John, or no decisions need to be made here? I'd like to move on to vaccination update.
Thank you.
Thanks, John. And so Carlin's on deck, and Carly.
I don't know if you got both of us today. I think we might have split up, but you at least got me. All right. Do you mind going forward? Awesome. So the general vaccination update is that we are kind of currently still working through that 1A, 1B above the dotted line. If you remember from the last meeting, the phrase above the dotted line is in reference to CDPHE's visual guidance that says that we have to work through sort of our healthcare workers, our first responders, COVID response personnel, and individuals who are 70 years and older before we move on to our essential frontline workers. So we are still doing that. We had a really successful week 2 weeks ago, and we were allocated 1,150 Pfizer doses from the state. We were able to administer those in 2 days at our Mass Clinic site at the Benedict Music Tent in downtown Aspen. So that was really, really successful. That was a phenomenal partnership with ABH and CHS and the Sheriff's Office, and there's too many to list here. But it was certainly a team effort, and it was really fantastic and really awesome to see. Last week, we were not allocated any vaccine, which was a bit of a disappointment after such a successful showing that we can do these mass numbers and that we do have the capability and capacity to manage that system. But we know that that's the case. We know that the state is working through their allocation and making sure that it is distributed in the most equitable way possible. So no clinic last week. This week, we did get 300 doses for Pickens County. 100 of those went to Mountain Family Health to serve their population. For that clinic, you do not need to be a patient of Mountain Family Health. They are doing sort of the general populace as well, but they certainly are serving sort of a focused population. So we're very grateful for them and the effort that they're taking. The other 200 doses were allocated to ABH and will be administered through the large clinic site again this Friday, the 29th. So that's very exciting. Second doses are well underway for our healthcare worker population and first responders. Those clinics were taking place at ABH and CHS over the last couple of weeks. But the very exciting bit is that we do have individuals from that most at-risk population who are fully immunized at this point. And that's really exciting to see. And I know all of our healthcare providers and all those individuals working on the front line, it's sort of a sigh of relief. So that's really awesome. So looking forward, sort of when we're looking at sort of making that transition into that essential frontline worker population, the state has set the goal of 70% of 70 years and older population to be vaccinated by the end of February. So for that, we seem to be pretty on track. We are hoping that as allocation increases, if we can get to that kind of cadence where we're getting thousands of doses a week, we could be able to pull through that population really quickly. As it stands, we have about 1,500 individuals who have self-identified as 70 and older on sort of our registration/vaccination notices list. So we do still have a ways to go through that list, but we are working through it. And as long as we still get the vaccines, we know that the system that we have in place works and that we are able to do that really high throughput, which is what we need in order to do this safely, efficiently, and as equitably as possible. So next slide, please.
Now, Carly, just wanted to, so I think I heard we were about a 33% or 30% of over 70s are vaccinated. Is that the number I heard?
Yeah, it's about at that point is right at around, and it depends on if we go off of our demographics that we have sort of from our census data, the pre-registration list, and then we also have different data for, our second homeowners and sort of that secondary population. So we are roughly looking at about a third of our 70 plus population being done. And most of that obviously was through that big allocation that we were given 2 weeks ago. So.
Thank you.
Thank you. All right, so we did have a little bit of a change up this last week. We are saying that not having a clinic, while disappointing, kind of allowed us to really focus on our messaging, our communications, as well as the tech side of what we're doing. So previously we had been calling sort of our sign up form the vaccination pre-registration form. There was a little bit of confusion around that language. So it is functionally the same form. It is found on the exact same website. We're just now calling it vaccine notices. And that is because this is the sheet that we are utilizing to notify individuals once we move into their phase and once they are eligible and able to sign up for that vaccination appointment. So it's just a little bit of language change, but it is functionally the same thing. The big takeaway from this is that if you pre-registered over the last month, I think we opened it on December 30th, if I remember correctly. If you pre-registered between then and now, you were automatically migrated into the new system. Do not worry about going back in and redoing the process. We made sure to cover our bases. So you are in there and we made sure of that. So ever so slightly, we just wanted to kind of touch on what this process is and what we're utilizing these systems for. So kind of the big step one is that you go through this portal. You can see the language that we have sort of on that sign up sheet on the vaccine notification form on the left-hand side. So you go through there. It's a very simple questionnaire. You self-identify as sort of your risk factors, the different variations in your employment that might move you in those phases. And so then you kind of get put into this database. As we go through our phases, we are using that information that you initially provided in order to sort of sort through all those individuals who were pre-registered / signed up for the notifications. We select all eligible individuals, and we will send out a communication when we know that we've received vaccine and when we know that we confirmed that we can hold a clinic. What then that does is it has a time that we will open the scheduling appointment link. And so that way we're trying to catch as many people as we can with that initial email, let them know that this is happening, to try to alleviate the fact that not everyone is attached to their phones or their emails 24/7, so that we give them a time that they can plan on going to that scheduler. So to that link to the scheduler gets sent out. They then click on that link. It comes up with all to a triage page, excuse me. The triage page is sort of what we're using to filter out anyone who might be trying to game the system. So it asks a little bit more in-depth information. None of it is stored, so we don't have access to answers to those questions. But it ultimately is pushing to people and trying to get people to be as honest as we can. So that triage page will, if you are not eligible and you might have received that invitation, or somebody may have forwarded you that invitation to the scheduler link, the triage page will boot you off and let you know that you will be vaccinated eventually. You are just not eligible for this clinic coming forward. So once they pass through the triage page, they come to the scheduler. The scheduler pops up with all of the available times and dates for those clinics, and they can pick whatever one suits their schedule best. They then receive, once they kind of go through that process, they will receive an email confirmation with that information. And then the week before the clinic, so the week before they get their actual shot, they will be kind of sent reminders by email, by text. They have to opt in for the text notifications, but that is a benefit. And so we kind of try to hit them on all fronts on that point. We really want to let people know that this is coming up and that they know what time their appointment is for. The big thing is that when that clinic does fill up, there are notices that are sent out to individuals who were not able to get their appointment, as well as on that scheduler page, it says that there are no more clinics, dates appointment. And so it kind of goes through that system.
Thank you, Carly. If I could, I just had just an experience I had. It was on the Eagle County forum. Sometimes people over 70 just aren't internet enabled or can't hear on the phone. Is there, for the signups, is there a form where, say, a helper, a caregiver can put their phone number and their name in for contact, just to make sure people don't fall through the cracks?
No, absolutely. And we've already been kind of working through that process, and I've personally talked to a handful of individuals that are like that. We also have a phone line that individuals who might not have internet access can call. It's up on that same website, just under the registration form, or excuse me, vaccine notices form. And so if you aren't able to access internet, if you aren't very comfortable utilizing email or kind of these different portals and links, we do encourage you to please call that hotline. As well as we are working on sort of extending those call time hours to make sure that we're able to fill that need. So
great, thank you. Really, I've heard nothing but really great reviews about the vaccination program so far. So thank you for that update. And I have a question from Ann here.
Yeah, hi Carly, nice to see you. How many doses have you requested for next week? And more important, how many do you anticipate receiving?
That is always the hard one to ask and answer. We requested about 1,500. So, and it depends on the vaccine amount. So Pfizer will only ship in about, they call it a pizza box, of 1,000. And so we have to request at least that many from Pfizer. And then Moderna ships in cases of 100. So we requested 1,500 when we received 1,000. We requested 1,500 when we received none. We requested 1,500 when we got 300. So it is anyone's guess. That being said, we are hoping usually the state plans on notifying us between Thursday and Friday. So we're hoping by at least tomorrow evening to know how many we'll be getting for hopefully the next week's clinic.
Charlie, if I could add into that, I've had a couple conversations with Jill Ryan, who's our state public health director, and I've heard that I think the state is allocated about 50,000 doses per week, and that it's doled out according to census. And it really comes down to us getting 200 or 300 per week, which seems quite low, but that's how it shakes out, believe it or not. And it's kind of a surprise to her also when it didn't arrive. So not getting it last week, I think, was a bit of a surprise. And I'm hoping that we get more and better information on that and a more regular stream. Thank you for that update.
Is that published
Brent has a question.
Just quickly, is that published anywhere? Where can the general public say, this is how many doses Aspen or Pitkin County will get this week?
Yes, it is. It's on the CDPHE website. It is public information. I will say it's not always the easiest to find. You kind of got to know that what you're looking for and how to dig through the website for it. I don't have it pulled up right now, but it is publicly available information. The one catch is that they only say what has been allocated. They're not saying how much is requested. So you will see that Pitkin County was allocated 0 doses last week and 300 this week. But we are not just requesting that. We are pushing for that closer to 1,000 if we're lucky.
Based on what Greg said, 200 to 300, if we were at 250 per week, that's 1,000, a little bit, we got 1,000 per month. Where does that put us moving into the next regime?
That will put us behind the state's current estimate for when they're hoping to be done with 70 plus. However, I would like to say, to Greg's point, this isn't necessarily a static process. So they are constantly adapting how they're how they're allocating vaccine going forward. They're taking into account counties that may have a smaller 70 plus population. And so if they're getting closer to being done with their population, they're going to try to shift that allocation into counties where they aren't quite as close to being done with the 70 plus population. And I think that was part of sort of why we got 1,000 and then why we didn't get any, is that it was sort of that balancing act is to have gotten 1,000 so early on, our numbers looked really, really good. We were kind of ahead of the curve, so to speak. And so I think the week that we received none, to Greg's point, there was a snafu at the federal level, which of course trickles down, but that we were ahead of the game, so to speak, at that point.
If we could hit the state mark, which it looks like we won't, how big is the next group?
That is, I hate to say this, I don't have a very clear answer for you right now. And that is because the state has just released guidelines about what that next group is looking like. And so in a press release and a press conference, Governor Polis mentioned that he's going to look at prioritizing teachers and early childhood learning centers first. And so that number we're looking at, I think, roughly anywhere between 600, 700 individuals. But then we start looking at the other essential workforces, and there is a policy group in place working at the public health as well as the IMT structure, sort of making those choices and taking the information in that the governor's pushing out and that's coming from the state level and sort of implementing that into policy at the county level. So right now I don't have a very tight answer. It really does depend on sort of when those guidelines get pushed down from the state level.
Yeah, but Brent, we have been doing outreach to employers that could make up that 1B2, I guess, kind of prioritization and getting those counts. So we do have a plan in place. There is nothing that's going to slow us down here, but we are adapting as has already been said, to priorities changing at the state level and such.
The nice thing to know is that we're able to take and administer anything they give us, and that's, we've demonstrated that, and they know it now, so they're not going to hesitate on that front. So we know we're able to deliver as many vaccines as they'll give us, and that's great to be in that position.
Do you mind just jumping forward one slide? We kind of touched on some of our future plans.
Carly, can I just clarify? You mentioned that the governor's press conference prioritized early childhood providers as well as educators through, childcare through 12th grade is what we heard. And we are still waiting for additional information to come out in an official capacity.
Yes, thank you, Jordana. So we kind of touched on a lot of this kind of through questions and through sort of what we just were discussing. But this week we are looking at second doses continued through CHS as well as ABH. They actually should have wrapped up, I believe, tomorrow. Mountain Family Health had their first clinic in in Pickens County in the Basalt location at the Basalt Middle School on Wednesday. That was really successful. And then on Friday, we have our Moderna first dose clinic. Next week, we're looking at a pretty busy week from the vaccination side. It's very exciting. We're getting our second doses for that large clinic. So we are doing another 1,150 second doses through the Mass Clinic site, as well as whatever allocation for first doses we're receiving. So we're pretty excited about that and looking forward to it.
It's great to see that. Thanks for sharing that with us. Okay, is that it? Are we done with the vaccine update? I guess that's a yes. I'm looking to you, Jordan. I see you there. I don't know if anybody else has a hand up. I'm going to keep us moving here. We had added a round robin to this, and I think it's important. So I'm glad you're grateful that you're all sticking around, whoever can. I know Dr. Levin had to leave. But I'd like to open the floor to questions or comments now. And if anybody has one, please raise their hand. I'm not seeing anything. I guess I'd like to say something just regarding the previous conversation regarding the motions that were put forth. I have to say, I think what I heard from Bill and from Tori had some real merit for further discussion, and I'm sorry to say that if we could have somehow put that in a form where even with a visual presentation and to be able to present a motion like that, it's complicated enough for me that I'd like to see it written down. I'd like to, perhaps it has to, if there's any way we can make sure that it gets to staff beforehand, whether or not the staff agrees with it, just so that it's in some sort of form where we can really look at it, examine it, would really help me in the future. And maybe we can endeavor to do that, just so that when a motion gets put forth, we have a better grasp on it before we're forced to vote on it. I think that's just my suggestion on how we might be able to improve the situation. I know it doesn't always work that way. There's so much to go through and so many wrinkles that can be thrown at this. It just seems like that might be a way to perhaps to create a structure where we can actually move a little bit more nimbly. That said, I haven't seen anything else. Does anyone else want to add anything here before we adjourn? Because that's the next thing on my agenda. If the round robin, we may have exhausted ourselves, but I want to give you all a chance.
When is our next anticipated meeting?
That's a Georgiana question. Thank you. Tomorrow.
Great question. We have, so we have adopted that our regular meetings will be quarterly. And so that quarterly meeting would happen on March 11th. I know that we're going to want to meet before then. And so that can be up for discussion. At one point, we were going to set monthly meetings on the second Thursday of the month, which would be February 11th, and try to see if we could move more towards that monthly cadence of February 11th, which would be 2 weeks from today.
I'd like to see us schedule one for February 11th, if not sooner, just so we've got it on the calendar and we're prepared for it, because I'm going to anticipate a number of things. I'm going to anticipate we're down below 700 well in advance of then, and things are starting to start moving again. But I'm also anticipating we're going to be hearing more about the variants, and there will be some other questions. We're also going to have vaccine questions, perhaps. So I would say the 11th sounds great, unless you all think there's a need to schedule one sooner.
I agree with that.
Thank you. I got a second on that. It wasn't a motion. I don't know if we need a motion, but Jordan, are we okay with that? And of course, if there's a pressing issue, a special meeting can be called, and it has to be noticed, but I think we can do that within, is it 24 hours or 48?
24 hours.
24 hours, thanks, Suzuho. Okay, if there's nothing else, I'm gonna look for a motion to adjourn, assuming I need one.
So moved.
I've got a motion and a second from Brent, motion from Dr. Kurt. Thank you all. That was exhausting. And I look forward to seeing you all again soon and hearing from you sooner. Thanks a lot. And that's it for today.
Thank you, everybody.